So there are several drugs that will have a positive ionotropic effect on the cardiac myocardium. So these are synthetic drugs like dopamine and isoproterenol that mimic the effects of epinephrine and norepinephrine by stimulating the influx of calcium ions from the extracellular fluid. So you find that these drugs will be able to stimulate influx of calcium from the extracellular into the myocardium, and that is going to intensify the contractility of the myocardium. So the myocardial cells are going to contract with a greater force. So also excessive calcium in case of hypercalcemia also act as a positive inotropic agent. So you find that when you have hypocalcemia, you have more calcium moving into the cells that will bring about a positive inotropic effect on the myocardium. Then there are also drugs like digitalis. So the digitalis lowers the heart rate but increases the strength of contraction, acting as a positive ionotropic agent by blocking the sequestering of calcium ions into the sarcoplasmic reticulum. So you find that it's going to inhibit the calcium ATPase pump that is found within the membrane of the sarcoplasmic reticulum. So if it's inhibiting the activity of that pump, calcium is not pumped back to the sarcoplasmic reticulum so that you can have myocardial relaxation. So that is going to increase the concentration of calcium in the sarcoplasm that will result into an increase in the contractility of the heart. So digitalis drug will have a positive ionotropic effect on the heart. So the contractility is going to increase, the stroke volume is going to increase, and the cardiac output will also increase as a result of this drug. Then there are factors that decrease the contractility, which are described as negative ionotropic factors. So this is just the opposite now. Instead of having the sympathetics, here you have parasympathetics. So the parasympathetics will decrease the contractility of the myocardium. So they will have a negative ionotropic effect on the myocardium. So you have the negative ionotropic agents that also include hypoxia, acidosis, hyperkalemia, and a variety of synthetic drugs. So these include numerous beta blockers. So beta blockers, they are inhibiting the influx of calcium into the myocardium, so they are going to decrease the contractility. So beta blockers like propranolol and pronetharol. So these propranolol and pronetharol drugs, they're going to inhibit the influx of calcium, hence reducing the contractility of the heart. And also we have calcium channel blockers. So these calcium channel blockers like dihydropyridine drug, then phenylalkylamine drug, so the phenylalkylamine drug and benzodiazepine. So these benzodiazepine, phenylalkylamine drug, and dihydropyridine drug, these are referred to as calcium channel blockers. So they will inhibit the influx of calcium into the myocardium. That will bring about reduction in contractility of the myocardium. So they have negative ionotropic effect on the heart. Then the last factor is the afterload. So the afterload, we said, this is the force to which the heart has to contract against the resistance for it to pump blood into the systemic circulation or the pulmonary circulation. So afterload refers to the tension that the ventricles must develop to pump blood effectively against the resistance in the vesicular system. So any condition that increases the resistance requires a greater afterload to force open the semilunar valves and pump the blood into the aorta or the pulmonary trunk. So anything that is increasing the resistance of the peripheral blood vessels will have an effect on the afterload. So it's going to cause an increase in the afterload, then that will result into an increase in the workload of the heart. That will predispose such a person to maybe hypertrophy of the ventricles, and then later on you can have heart failure. So damage to the valves, such as stenosis or those semilunar valves in this case, which makes them harder to open, will also increase the afterload. So if the valves are not opening, as much as the ventricles are trying to pump blood into the systemic circulation, pulmonary circulation, that is not taking place well. Why? It's because the valves are not opening very well. So it means the resistance has increased. So the afterload has increased. So any decrease in the resistance decreases the afterload and the cardiac output will increase. So this diagram here is just summarizing the three primary factors that will have an effect on the stroke volume. So you have the preload, afterload, and the contractility at the center here, the contraction of the myocardium themselves. So you have the preload, the volume of blood in the ventricles at the end of diastole, so end diastolic pressure. Increased in hypervolemia, so if you have increased volume of the blood, you find that the preload is going to increase. Regurgitation of cardiac valves and also heart failure is going to result into an increase in preload. Then afterload, the resistance left ventricle must overcome to circulate blood. So increased in hypertension, so you have hypertension, vasoconstriction is going to result into an increase in afterload. You have an increase in output. The output, but the cardiac load is going to increase. That will predispose to different so these factors that are affecting the stroke volume are also summarized in this table. So you can see you have preload, contractility, and afterload. Also contraction. If we discuss, then we're going to have an increase in contractility, increase in stroke volume, which is straightforward. Increasing against which the heart has to pump the blood. If you have an increase in the pumping less blood to the circulation because there's just too much resistance. So if there's an increase in the end systolic volume, of course you're increasing the volume because you have less of it. You have a decrease in the load volume. The heart is able to pump much of this blood now into the systemic circulation, pulmonary circulation. That will result into an increase in the stroke volume. Okay, so this is just the relationship of all the factors, putting them together so you can see you have the cardiac output, the heart rate, the stroke volume, and these factors are the ones that will have an effect on the heart rate and the stroke volume, because the cardiac output is the product of the heart rate and the stroke volume. All these factors that will have an effect on the heart rate and stroke volume will also have an effect on the cardiac output. So for instance, on the heart rate, you know to say that the venous return will have an effect on the heart rate, and also it will have an effect on the atrial reflex. And you know factors that will the first part of this leg, the muscle pump, that blood volume will have an effect. If the blood volume is increasing, the venous return is also circulation, will also have an effect on venous return. So if you have an increase in venous reflex, the autonomic nervous system, then you also have hormones. These hormones, catecholamines, that will have an effect on the heart rate, and also thyroid hormones, glucagon hormone will also have an effect on the heart rate. This heart rate will have an effect in the diastolic volume because the filling time is just increasing the volume. Because if the filling time is increasing, the end diastolic volume is increasing. The period is one way of expressing the end diastolic volume. So the end diastolic, so an increase in diastolic volume increasing, and this period will have an effect to increase volume is going to reduce. That will result into an increase in the stroke volume, and cardiac output is also going to increase. Then these hormones, this is going to increase. So you have those acetylcholine and norepinephrine that are parasympathetic respectively. That will be of the myocardium. Then that will have an effect on the end systolic volume and the stroke resistance to which the heart has to pump against for it to eject blood into the systemic and the pulmonary circulation. So changes in the peripheral circulation, if there is an increase in resistance because of hypertension, that will increase in afterload. If the afterload is increasing, volume is going to increase less blood into the aorta, will reduce. Increasing volume related, but you can see in factors. Then the last slide, like I said, measurements of the cardiac outputs. I don't think we have enough time for me to explain everything here, but just not to say that you have two methods in which you can measure the cardiac output. You can use the direct or the invasive method. So you have the direct or the invasive methods, which are the FIC method and the indicator dilution method. And then the other ones are indirect or non-invasive methods, like echocardiography, which I said is just the ultrasound of the heart. And then you can also have computed tomography. This is CT scan. You can also use CT scan to calculate the cardiac output. Then you can also use radionuclide imaging. So the radionuclide imaging is whereby you inject a radioactive substance into the body of the patients. They need to be able to produce those emissions. Then the machine will be able to pick them up, and then it will be able to calculate the cardiac output. So these are different methods in which you can use to estimate cardiac output. So in most cases, the non-invasive are the ones that are used to estimate cardiac output. But because the invasive ones are accurate as compared to the non-invasive ones, but I mean, you're dealing with a patient, so you wouldn't want to use a method which is invasive because it requires you to click to introduce transducers, to introduce terminals within the cardiovascular system. So it's very stressful. So because it's very much dangerous to do that on a patient, so you don't want to overstress the patient. So it's better use the non-invasive. So in experimental designs, we can use the invasive because they are very accurate and precise. So the precision there is high. But if it's just on a patient, you just want to estimate, you want to look at the cardiac efficiency or how the heart is working, then you can use the non-invasive, the echocardiograph, which is very common, the CT scan, very expensive, but you can use it. Then you can also use the radionuclide imaging. So the FIC method in experiments, it's used. So the FIC principle states that the amount of the substance taken up by an organ per unit time is equal to the arterial level of the substance minus the venous level. So you're talking of arterial-venous difference times the blood flow. So if I give you an example down here, you can see, if you're using the FIC method to estimate cardiac output, let's use oxygen consumption. So the rate of oxygen consumption is the amount of oxygen that is introduced to the lungs. Then the consumption of oxygen is the difference between the venous level of oxygen and the arterial level of the oxygen before it returns to the lungs. So you'll be able to know how much of oxygen has been used by the body. So by using these values, you'll be able to estimate cardiac output. So the blood flow here, or the cardiac output, will be equal to the rate of oxygen consumption divided by the oxygen content leaving the lungs. So you're talking of the venous level of oxygen, then minus the oxygen concentration entering the lungs. So the concentration of oxygen in the pulmonary arteries as they are entering the lungs. So the difference is what has been used by the body. So for instance, if I give you the value of the oxygen consumption to be 250 milliliters per minute divided by, let's say, the the amount of the concentration of oxygen leaving the lungs, let's say it's 190, and that entering the lungs is 140. So you get the difference here. So 250 divided by the difference of the two, you get about 5 liters per minute. So this is just FIC method of estimating cardiac output. So I want you to read on this topic. So you need to understand the invasive methods and the non-invasive methods, of which in most cases, we normally use the non-invasive because you're already dealing with a patient, so you don't want to overstress the patient. So it's better just use the non-invasive, which is just simple and straightforward. At least they will give you an idea on how the heart is functioning. So with that information, thank you very much. Until we meet next time.